I'm so glad that I got to do this series with you guys in the order in which we did it, or the first two could be switched a little bit, I guess, but because I really feel like we do a nice overview with dual diagnosis generally. We dig in a little bit more deeply with trauma, and then this to me is sort of the other side of the coin. And just to give you a little background on this, I started becoming interested in vicarious trauma and secondary traumatic stress, I'm going to say maybe 5 or 6 years ago. And it just happened to be something that I started learning more about and reading about, and did some presentations at conferences. And then COVID hit. And so I'd been doing this for a couple, maybe 2 or 3 years, and then we had the pandemic. And so a couple of things happened. One is that I got to see play out in real time the factors that contribute to things like burnout and secondary traumatic stress. And it also, it just seemed to line up in terms of how important it is. And I think it will continue to be important to really look at the well-being of helpers, whether we're talking about medical professionals, first responders, mental health folks. We're going to see a tsunami of people retiring or leaving their careers completely, I think. I don't think the wave has hit the high tide mark yet, actually, because of some of the damage that people sustained during the pandemic trying to do their jobs. So to me, this has become more important ever than before, even though it was already something really near and dear to my heart. So I'm always really, really grateful that I get a chance to spend time with people, and that we've got this time today to talk through some of these things. It's also helpful, I think, to start with a mindset of this is not something to add to your to-do list. I don't know about you guys. And Michael, I definitely want you to feel included and part of the group. But I will say that for women in particular, I do feel like there's this constant to-do list in my head that is never done. And there's always more crap to put on it, right? Like, oh, right. Also, I need to be running a quarter marathon, and I need to be eating a kale salad and blah, blah, blah. Like, so what I wanted to really look at was the first half we'll spend talking about what are some of the dynamics involved with what we consider burnout or compassion fatigue, which is another term I use, and I'll explain why. And then looking at what are some of the building blocks or principles of how we recognize and address our own emotional well-being. And you will not find kale salad anywhere on there. So if you love kale or you want to go to join a yoga class, great. You should do those things, but it's not about yet more things you are failing to do. And again, I think all human beings need to hear this, but especially women. I don't know about you guys, but there's a channel in my head, and if I tune to that channel, I'm failing at everything all the time because there's always something I'm not doing, and that's what I wanted to avoid. So we're going to be talking about this in a different way, and hopefully we'll avoid that vibe. So let's jump into this. I love this. You guys are probably familiar with Pema Chodron. She's easily second only to the Dalai Lama, the most recognizable name in Buddhist thought in America, I would say. She's an American woman who is also a longtime Buddhist monk or nun, however you want to describe it, however she would describe it. And she says something in her classic book, The Places That Scare You, that we're going to use to sort of set the tone for the training. She has a book out really, her most recent book is called something like The Way We Live is the Way We Die. And I recommend everything that she writes. She's very no nonsense. There's no airy fairy fluffy stuff. And she's very, very practical. But this quote in particular from The Places That Scare You, I really felt resonate during the pandemic. We can let the circumstances of our lives harden us so that we become increasingly resentful and afraid. Or we can let them soften us and make us kinder and more open to what scares us. We always have this choice. And I chose this quote because when I first read it, I'd read The Places That Scare You long ago, and then I was looking at it again during the pandemic, and I did not care for this quote one bit because I felt so overwhelmed with fear and worry and stress in the early days of the pandemic, that the idea of being open to that just felt like, like just sort of, making a bigger target on your chest so that you can be hit with arrows more effectively. It seemed so counterintuitive and so scary, frankly. And so I wanted to start with this because we'll really delve into how do we stay open, but in a skillful and self-aware way that actually insulates us from the stress of the pain and the fear that we're exposed to every day as mental health professionals. So we'll come back to this, and I feel like there really is a way through with this idea. So more shapes and colors. I'm so excited. This is just not my natural habitat. So secondary and vicarious traumatic stress, if you've done any research or reading into this, you may find that people use these terms a little bit differently at different times. I will tell you the way I think of them, but don't get too hung up on the terminology. So someone might, switch it, and that's obviously fine too. When I think of secondary traumatic stress, what I think of is kind of that second wave of the event. So you are not the primary, you are not in the primary, let's say, radius of the event. So there's a house fire or someone ODs. You are not the person in the fire. You are not the person ODing, but you are the first responder who's first on the scene, or you are in the emergency room immediately after the fire where the patients are taken. So you get the, in real time, a close sort of blowback from that event. You're on the heels of that event. And there are some forms of social work where we do that. Where I think it gets a little trickier unless you're in mental health and you do crisis response or you work for the Red Cross or something, you're unlikely to do this. And in DD, even more so, this is not what people are typically exposed to. There aren't emergency room DD people the way there are emergency room social workers. Although maybe we should have them. But I think that the rarity of it means that people, especially in the dual diagnosis DD world, are more vulnerable to it when it happens. So I'll use an example that I typically go to. We were consulting in New England and had a whole day of training planned, and the day started at like 8 or something. And we were going to have, it was a fairly large provider in the area, and they had a group home with the staff. The overnight staff was going to come join us coming off of their shift, which I thought was like amazing. I just wanted to let them go have a nap. But right before we were getting ready, it was like, maybe 10 minutes before we started, a manager pulled us aside and said that in this particular group home, they'd had a really severe choking incident where the individual almost lost their life on the site. And fortunately, they did everything right. They called first responders. The first responders were able to intervene. The person was taken to the hospital and was going to be okay, but nearly died from this event. And it was a small staff. I think it was like maybe 4 or 5 people that were on site. And just as they were talking about this happening, you could see this group walk in. They'd all driven over there, whatever, and you could see it. They were pale, they were withdrawn, they weren't mingling and getting donuts and chatting the way the other people in the room were. There were about 100 people there. And fortunately, because we had this warning from this very thoughtful manager, we switched the morning around, and we started with some grounding and breathing just to try to help them manage the stress of what they had just experienced. And what that really taught me was that if you are law enforcement or EMT or emergency room, there's wear and tear that you get from having that job, but you do have the advantage of sort of mentally putting on your armor every day, right? You kind of know what you're likely to be walking into for that day. And even in mental health, if you are used to working with a highly traumatized population, or in my case, most of what I work with in my private practice is trauma and grief and loss. When I first sit down with a client, even if I don't know anything about them, I can sort of mentally put that little hazmat suit on. I know what I'm likely to experience in that room. With DD, they have no sense of that at all. So while it may not happen very often, that kind of that second wave of the traumatic event, I do think they can be vulnerable to that, and they don't have the experience of kind of mentally preparing for it. So that's secondary traumatic stress. And we do sometimes experience that in mental health or in DD. The other kind of traumatic stress, and again, this is where the terminology gets used a little differently, but it makes sense to me. For me, vicarious trauma is where I am nowhere near the event. The event or a series of events may have happened hundreds of miles away and decades away from me, but I'm potentially re-experiencing it as I'm listening to the story. So that, like that trauma scrapbook that we were talking about, that sounds awesome. Well, if you're the therapist working on that with somebody, you're hearing all the trauma stories, right? And no matter how much experience we have, if your heart is still alive inside of you, there's some pain that we experience, even if we've learned how to think about it and rationalize it and make space for it. It's painful to hear those stories. It's still painful for me. And as we'll talk about in a little more detail later, the real problem with vicarious traumatic stress is that, even if Megan is telling me something that happened decades ago, as she tells me the story, there are two possibilities for dysregulation. The first one is she tells me something that triggers my trauma, because we all have we're all humans, right? We may have our own stories, our own traumas. I can be triggered by stuff, even though I've done a lot of work on my history. I'm still human. But the other thing, and this is, I think, more insidious and will lead us into a conversation about empathy, is that I said earlier that all of us in this room, I feel like I know you guys well enough, or even when I'm talking to audiences of hundreds of people, the vast majority of people are in the room because because helping is important to them and because they're good at it. And what makes us good at helping is, or, even if we're a supervisor and we're primarily helping our staff, what makes us good at it is that we're very empathetic people. And that's really the vehicle for the good and bad of our work. And we're going to go there in just a second. But briefly, I'll just say it this way. If I'm empathizing with Patricia and she's becoming dysregulated, talking about her trauma or reliving her trauma or whatever it is, and she goes into that hyper arousal or hypoarousal, if I'm empathizing and I'm closely connected with her, guess where I'm going to? Now, it may not be as high or as low as she gets. Hopefully it's not. But I'm kind of along for the ride, right? And I think that is one of the engines of the wear and tear that we see on people who work with trauma. And again, I think when you are working with DD providers, being sensitive to that, they are not equipped for it. And they also don't always have warning. So the therapist I'm sorry, who was talking about the scrapbook? Was that you? Was that Candace talking about that? No, that was Patricia. Okay. When you sit down to do that, again, you can sort of go, here we go, right? And you kind of know what to expect and what you're doing. Now imagine that you are an hourly worker, a DSP worker, you're making spaghetti with me on a Sunday night. And in the middle of making spaghetti, I start saying, the last time I made spaghetti with my mom is when my stepdad got taken away by the police when he hit my mom with a bat, whatever. And you're like, what? There's no, I might not identify it as a trauma narrative. You have no idea it's coming and boom, suddenly you're hit with it. Or, as we talked about last time, especially if I can't even give you the story, I can't even give you a context, but I am suddenly dysregulated. So I'm aggressive, or I'm frightened, or I'm in my fight, flight, freeze, fawn, who knows why, or I'm dissociated and collapsed. There's no mental preparation that you're doing. You're living out the trauma with me, and maybe you have no idea that's what's going on. The word trauma might not even be in your head, but that's what we're now both living together, right? So this is why people in DD may not be as exposed to trauma day in, day out the way I might be in my trauma practice, or that an emergency room physician is, but it's more insidious because they may not even know that's what's happening. So it always makes me think of radiation, right? When people get radiation poisoning, often they have no idea it's happening because you can't feel it, you can't smell it, you can't taste it, you don't know what's going on, but it's causing profound damage, right? So this is why I think it's so important, even with the fields that seem a little more removed, that they get this same kind of training and awareness and resilience building. So when we talk about, let's see what comes next, burnout. Yes. Okay. So if you study burnout, and there are a lot of experts in the field, again, people kind of vary in how they talk about it, but burnout tends to be a more umbrella term that includes external factors as well as internal factors. So burnout often is identified with some things that are out of our control, like caseload, pay, access to resources, quality of supervision, workplace culture, stuff like that. All of those things can contribute to burnout, and that is beyond the scope of what we were talking about today. But the internal factors of burnout are what we've been talking about: secondary and vicarious traumatic stress. And a term that I personally find rather offensive, compassion fatigue. It's kind of going out of style, which I'm glad about, and I don't use it. But for the moment, when you look at burnout and compassion fatigue, and if you see the little like surveys you can take online or whatever, compassion fatigue refers more to the internal processes. So kind of the emotional wear and tear that we experience internally from the work we're doing. And briefly, yeah, we have to talk about this for a second. So moral injury, those of you with a trauma background may recognize this. This wasn't as commonly talked about. We're seeing more of it directly as a result of the pandemic. And we're seeing more conversation about moral injury, specifically to doctors and nurses, when their ability to provide care was severely limited by the pandemic. Not having enough beds, having to make choices about who got treatment and who didn't was very, very damaging to people. And I would argue that we had versions of it in social work and mental health and DD as well. So for those of you who are familiar with it, like a lot of trauma, we learned about this primarily through military trauma. When we think about PTSD and trauma in the military, we tend to think about what was done to someone or what they witnessed being done to people. Moral injury refers to the damage of what we do to people. So when soldiers cause damage or harm, and especially, I apologize, especially if it goes outside of the bounds of what are considered the conventions of war, right? So a soldier may grapple with the damage of harming another or killing another soldier, but when civilians are involved, when children are involved, there are other layers to moral injury as well. But basically, it's damage to our ability to see ourselves as good moral people, or it's a violation of our morals or ethics as people. And while we are unlikely, yes, do I have a hand up for a question?
Yes, I just wanted to
Nope,
know.
just chilling. Okay.
No, I do have a
No, I
question.
do. There is a question. Okay. Oh, I'm sorry. I think I've got you muted. Here. Sorry.
Okay.
Do that. Let's try
Uh,
that again.
so I was thinking of moral injury in terms of like sometimes when I receive a call from a client that I know is going to be dramatic or something, and I choose not to take the call,
Yep.
sometimes feel that
Yes.
moral injury because I feel obligated to do it, but am I in the mental space or have I taken on a lot at this point in the day that, oh, I can't do it right now. I call them later, but I, you
Oh my
know,
gosh. We're going to talk all about that. And I can't, you're a little bit off camera. Who am I speaking to?
Andrina.
Oh, Andrina. Okay. There you are. Hello. You just did so much important stuff. I probably should send you like $5. That was so good. And it sets me up perfectly for what we're going to be talking about. I'm going to argue that we're going to work on reframing that to hopefully have that feel like a healthier response. But that is a perfect example of like of if you take that and you multiply it, that's what moral injury is, right? So you and I might talk about, actually, Andrina, that's a really professional, skillful way to be emotionally available. You know what I mean? Like I think that's a very professional decision, but I get the distress, and that's something that we're going to work on. But now imagine that times 100, and that's moral injury. And that, I think, again, gets kind of lumped in under burnout, but that's what we're going to continue to see. We're going to see in the next 5 to 10 years, and it's already started, but we will continue to see an exodus of people, I think, from all helping professions, partly because of that. So you are exactly right. And I'm going to come back to that a bunch of times. Where we saw that, oh, I'm sorry, Michael. Yeah, go ahead.
No, because I just want to piggyback off Andrina. So when I'm looking at, and I don't like the word compassion fatigue as well, but I'm looking at the burnout. And so because we're service providing agency and we go out and see clients on a general, I think our contact with them generally has to do with some type of stress related anxiety issue. And we're trying to solve that. So if you're looking at 5 or 6 or 7, 8 people, I always struggle with the fact that at what point of the day is all that anxiety that I'm carrying from one client to the next client to the next client, how does that affect my performance overall?
Oh, absolutely. Oh my gosh. Yes, so much. So we're gonna talk about all of that stuff. I will say this. Most of us are not going to deal with the kind of moral injuries that soldiers deal with in terms of I caused harm, especially if I caused harm to someone I see as a non-combatant or whatever. But where we experience it, and you guys are both touching on this, I think, really sensitively, and how the pandemic blew that up is we as social workers, we as people in the mental health field have always had to grapple with, there are more people than there are resources, there's intergenerational trauma. We've got, this family is messed up 6 ways to Sunday, and there's only so much we can do for them. You know what I mean? So I think we've often dealt with the barriers to providing the kind of help that in a perfect world we would do. What the pandemic saw was when we were drastically limited, even from what we were used to grappling with, right? So what we may have been used to might have been sort of low level and might long term, if it wasn't identified and it wasn't supported, then I think that long term that leads to the burnout or the compassion fatigue. But so it's kind of like the difference between chronic and acute, right? I think in our professions, we maybe were dealing with sort of a fairly stable chronic version of that distress. And then the pandemic jacked it up into this acute category. So I don't know if I included slides about this. Yeah. Okay. So without getting too into the weeds about this, moral injury can be caused not just by, as I said, doing harm, but by failing to do something helpful. And there's a sort of a subset of moral injury is moral distress. So to go back to your example, Andrina, maybe you experience a feeling of moral distress. And if it happens over and over, if it doesn't get supported, if it doesn't get reframed, if you're not finding other ways to, to feed yourself and build your resilience, then over time it's like a stress injury that turns into a bone fracture. If it doesn't get addressed over time, it can cause more and more serious damage. So constraint distress, again, don't worry about the terminology so much, but just to paint the picture, constraint distress is I can usually do X amount for my clients, which is not enough, but at least it's X. And now I can only do Y. And uncertainty distress means I no longer know what the helpful thing even is, right? So I did a training while we were still in the pandemic, we were still in lockdown, and I did a training in Franklin County with home-based folks who did early childhood home-based. So they would go to families' homes, they would do a lot of floor-based stuff and play and whatever, and teach the parents how to play and all of that. And they had to go to virtual during the lockdown, like we all did. And they talked about their distress in 2 very specific ways. One was, there are some families who don't even have an iPad. Like, I don't know how to get them what they need to be able to connect with me. And I think that was the uncertainty distress. I don't even know where to go from here to try to get this to happen. The constraint distress was, I remember this one woman in particular said, my identified individual is the kid, the 3-year-old, whatever. But I know that I'm really treating the whole family. And for some of my families, my visit for a couple of hours a week is the most stable time of their week. The parents get a break. They've got someone else there. The kids aren't being screamed at, whatever. I know that this is an anchor for this family, and now they don't have it because I can't do it in the same way. So those are just 2 small examples of, I don't even know what to do. Or like in the early days of the pandemic, before we had any kind of treatment for COVID, doctors were like, I can maybe treat the symptoms, but I don't know how to treat this virus, and I can't save my patients. That was incredibly distressing. So again, it's kind of like, we talk about potentially traumatizing stress versus a traumatic injury or, a post-traumatic disorder. Moral injury is kind of the same. If it's a little bit of stress here and there, we can probably work with it and recover. If it's really severe or if it's ongoing and untreated, that's when we start to see it being an injury. And I believe that, just like with PTSD, it may get to a point that it's incapacitating and people just can't do what they do anymore. Which is why I'm so passionate about this, because I don't think we can afford to lose anybody. We can't afford to lose any of you guys. So again, we could spend all day on moral injury, but I feel like that's not as talked about and needs to be a part of the picture for us as helpers. Okay, so I went online, and there are lots of things out there for burnout, for compassion fatigue, even now increasingly for moral injury. And I try not to spend a lot of time on this, because if you guys are anything like me, you'll just spend the whole time diagnosing yourself. So just a little caveat that we all experience some of these things sometimes. And if you notice that you're sort of mentally endorsing a lot of the things on this list, just be nice to yourself. Don't freak out. But it might mean that this is an area to bring some attention to. So this is not diagnostic, but it does just sort of kind of orient us to the water that we're swimming in. Okay. And what I did was, when I looked at all those different kinds of surveys and instruments, I just sort of picked the ones that seem to have the most overlap. And there's a lot of overlap among them. So I kind of distilled it to the ones that I thought were the big items. We're going to go through these kind of quickly, but there are a few that I'll talk about. Difficulty managing emotions. Yeah, I've known this about myself for a long time, but especially during the pandemic, I would spend all day on video calls. And then, like many of you guys, I'm sort of the emotional caretaker for a lot of people in my life, which is maybe not so great for me anyway. But when we're all in the same freak out, it was extra exhausting. I had less and less and less to give. So what I noticed was my irritability skyrocketed. I was much more snappish. I have an Irish temper already, so that's not so great for me. But I was more irritable. I was more tearful. I just felt like my emotions were, like when you've got a cup that's overly filled and you get that dome on the top where the surface tension's just holding it together. That's what I felt like most of the time. Feeling emotionally numb or shut down, which, as we remember from trauma, that's just the other side of that range, right? So when we're at the top of the arousal range, we're in fight, flight, freeze, fawn. We feel very activated and frantic. Numb and shut down is just the other side of that same coin. And most of us are capable of going to both places. Some people may go more to one than the other typically, but we're capable of both. And I certainly noticed other times when I felt very numb, very disconnected. Fatigue, sleepiness, or difficulty falling asleep. We talked about this a lot with trauma. The networks in the brain that regulate sleepiness and transitioning to sleep and transitioning back into wakefulness are very sensitive. They are the canary in the coal mine for the brain. And it doesn't, for many of us, it doesn't take much to throw it off. So this is an early indicator for me. Also, I went through menopause during the pandemic, not recommended, and I haven't slept in like 2 years. So just FYI. Those of you who are young, enjoy your skin elasticity and get ready for no sleep. Okay. This almost doesn't need to be mentioned. Physical problems, aches, pains, decreased resistance to illness. I read a statistic somewhere, I don't know if this has ever been replicated, but someone estimated that about a third of the population just typically tends to register emotional distress more somatically than the other 70%. So you may be less likely to identify anxiety or sadness or depression, but you're aware of an increase in headaches, stomach aches, muscle cramping, lowered immunity. We all can manifest those things as a part of emotional distress. Some of us, that might be more of a go-to. And we all are now, immunologists. We all got multiple medical degrees during the pandemic. And so I don't think I need to tell any of you the impact of stress on the immune system. We also know, I think I mentioned this before, that if you are already prone to some autoimmune diseases, stress may be, again, very complex mechanisms, but stress may be an on switch to those. So you may notice an onset or more flare-ups or increased severity of autoimmune diseases in particular in response to stress. Although we're now finding that there may be many, many more diseases that are more impacted by stress than we thought. So that's a fascinating area of research right now. Relationship problems. Yeah, you're hard to be around when you're like this. I don't think I need to say any more about that. I would also point out, I think we all kind of get that. I would say one other thing that for me, with my client base, what I've observed is that sleep is again an early warning, like that canary in a coal mine, and sex is another one. Stress is a killer for libido, number one. Number two, when you think about, and now we're talking about emotionally connected sex, and obviously not all sexual activity is, but in order to be emotionally present during sex, there's actually kind of a narrow window where you are activated, obviously, in one sense of the word, but you're also relaxed and very safe in another way to be emotionally connected. And that's kind of a delicate balance. And so for me, one of the things I've learned to listen for with my clients, even though they may not be identifying it this way, they may not see the connection, but when they talk about, yeah, my libido's in the toilet, I just don't feel it, or, yeah, I keep my partner wants sex, so I have sex, but I feel like I'm not, I'm kind of observing from across the room, I don't feel connected, blah, blah, blah. Or I'm avoidant of sex. That to me can be, I just make a note of it, that can be an indicator for increased stress. So their stress and sex or sleep and sex are kind of similar for me in that way. This one we all recognize: decrease or lack of or decreased participation in activities that used to be enjoyable. You guys know this, most of my audiences don't. When you say the word depression to people, they think sadness. We know that it's actually apathy and lack of interest, lack of pleasure. Those are actually the hallmark experiences of depression more than sadness. Obviously, there can be a lot of sadness with depression as well. But if you're talking to people and you ask them if you think they're depressed, they're more likely to say no if they're not experiencing a lot of sadness, but they may be experiencing a lot of apathy and anhedonia. And that's actually a more central experience to depression. Okay, this one, and there's some stuff that you guys talked about, and I think both Michael, you and Andrina both kind of touched on this a little bit. We are all human, right? So I absolutely can look at my week and go, there's some clients and some families that are a delight, and there are some that are less so, right? And that's just, once again, that's just human. For me, what I've learned to watch for is the difference between, I just need to get through Thursday morning, or whatever, versus a feeling of dread or actual avoidance. For me, I think I'm one of those people that tends to experience things more somatically. So my stress will be, I will not draw you a super detailed picture, but there have been times in my work life where I've been so overwhelmed with what was going on that a difficult client or a difficult meeting would actually cause physical symptoms like the night before. I'd have trouble sleeping, I'd have tummy troubles, I'd have headache, there's a difference between, this is a harder part of my week, and existential dread, right? So whatever that is for you, it may be sort of subtle, but I think we can, especially if you've been doing this for a little while, you kind of know what that feels like when it's more intense than it should be. And if you find yourself avoiding, I think I'm too sick, or you find ways not to be doing the thing that you need to be doing, that might be sort of moving into an area that you want to pay more attention to it. This is not new territory for us. There are lots of different ways that human beings self-soothe. This is not about judgment. But if you are aware that there's something that you do, whether it's a behavior or a substance that you use for reduction of distress, and you're doing more of it, or you're doing it to an extent that it might become its own problem, that's worth paying attention to in a very non-judging, compassionate way. negative self-image. And you mentioned this, Andrina, we're going to talk a lot about this, but when we believe that we have to be always available to people and that our value comes from, never saying no, then this is a big stumbling block for us. And again, Michael, not to exclude you from this, I think men can certainly experience this, but women in particular, we have been given the message in so many different ways that we're the glue of the family, we're the caretaker, we're the go-to, we're the friend that people love to talk to, blah, blah, blah. I think like everything in life, there's a light and a dark. I hesitate to say good, bad, but there's a place where we can use our gifts in a really beautiful, healthy way. And there's a place where it becomes destructive. We cannot be all things to all people. And again, just speaking for myself, I got to the point during the pandemic where I avoided, I'll tell you two stories. One was that I started avoiding family group chats, family FaceTimes. We were constantly being bombarded with like, stay connected to your friends with a virtual coffee chat, which sounds great. But if you're a therapist and you've been on the computer all day, every day, I could not do one more Zoom, couldn't do it. But I was also aware that I just couldn't listen to more people being upset. I couldn't. I will share this with you guys. I have a sister whom I'm very close to, and I love being the person that she can talk to when she's worried or freaked out. I couldn't keep doing that to the extent that I normally would, because I just couldn't. My cup was full. That doesn't happen very often, but it was happening on a weekly basis during the pandemic. The other thing I did, and this to me, I thought of this immediately, Andrina, when you were talking. I typically will take 2 weeks off at the end of December, which my clients hate because that's when they want to see me the most, right? The holidays are, that's when everybody wants like 2 sessions a week. But I've learned that that's the time I need to take to be with my family and talk to my therapist. So typically I'll take those last 2 weeks of December off, and my clients are always very gracious about it. The first year of the pandemic, so that would have been December 2020, as we were coming up to December, I realized that I was done in a way that I had not been before. And I decided that I needed to take 3 weeks, which is not typical for me. And I knew it would be hard on my clients. It did not feel good, but I also knew that I was at the end of my rope. And so, again, I have lovely clients and everyone was very gracious about taking care of myself, but I had to really work with some guilt feelings that came up. But I had to prioritize my own well-being. Yes, ma'am.
I think what I experienced is this level of dissonance
Yeah.
that, no, I could have delivered this better. I could have did a better service, but
Yeah.
I'm so
Yeah.
burnt out and I don't want to just totally or completely, do away with somebody. But, I don't feel the best about a service or a conversation or even a session that I did with a client. And I don't know, I struggle with that.
Yep, absolutely. And that takes us into even deeper territory, but I'll say a couple of things. One is that I also grapple with that. I think a good therapist thinks about every session, and you walk out thinking that went great. I might be a genius. And there are other sessions that you're like, oh, okay. And then there's some sessions where you're like, I should have gone to dental school like my dad wanted. So, I do think it's a balance, right? So being a good practitioner in whatever you do, as a supervisor, as a clinician, as a behavior analyst, whatever it is you're doing, there is that evaluative part, and we are always trying to pay attention to that. But I've also learned a couple of things, and one of them, this just personally for me, it may or may not resonate for you guys, but I've learned to trust the process. That, for example, in clinical work, and not every session is going to be great, or I miss something in a session. And I can do a couple of things with that. Number one is I can trust that I'm going to have another shot at it. Number two, sometimes depending on the situation and depending on the client, I'll bring it into the room. And when I'm able to talk about and model some self-forgiveness and tolerance of, you know what, you said this thing and I thought about how I reacted and I realized that I think I really missed that. And being able to model that, I think becomes its own therapeutic moment, right? So I've learned to trust some of that. And finally, what I've learned to trust as well, I usually talk about this at the beginning, but we'll talk about this now. So when I taught my students about this, I would use this story from Doctors Without Borders. I read this like 20 years ago. This doctor was talking about being involved with Doctors Without Borders. I think he was in Haiti. And he said that when he first applied, you go through this like multi-step application and you do, you know, multiple interviews and all of that. And he said, as he was, you know, first being oriented, they were like, hey, we require all of our doctors and nurses to eat 3 meals a day and get 7 hours of sleep a night. And he was like, well, yeah, I'm a doc. That sounds good to me, right? Good advice. And then he got a little further into the interview process and he was, you know, being considered as a candidate. And they said, you know, it's important to remember, we require you to have 3 meals a day, sleep at 7 hours. And he's like, thanks, got it. And then he was accepted and was about to go to his assignment. And they said, listen, super important, 3 meals a day, 7. He's like, yeah, I got it. And then he arrived, I think, at a clinic in Haiti, and he said he understood for the first time why they had kept saying it. Because he said there were people who would start walking in the dark for miles to get to their clinic when it opened at whatever time in the morning. And there was already a line at 7 or 8, whatever it was. If they would stop for half an hour to eat lunch and they closed the door, there'd be a line of people. And when it didn't matter what time they stopped at night, when they stopped the day and they closed the door, there was a line of people who would either walk miles back home or camp out there to be there the next morning. And he said he understood for the first time the depth of what they were talking about. And he said it became painfully clear to me that if I did not prioritize and schedule and rigidly stick to, I will eat 3 meals during this day, and we will close the clinic so that we can all get 7 hours of sleep to be able to do it again. He's like, there was nothing fluffy about it. He's like, because if you didn't do this, if you tried to meet the demand that was there, you would collapse from exhaustion and maybe die. And nobody's got time for that shit.
Right.
Nobody's got time. Nobody's got time when you collapse on the floor from exhaustion or whatever. And so he was like, I took it seriously in a way that I had never taken it seriously before. And so what I taught my students from that is when you're making those decisions, Andrina, you are quite literally ensuring that your clients are going to be able to get help from you the next day. And if you don't do it, they won't. And nobody is going to be able to take care of that for you, right? Fortunately, it's not quite as dire as being in a clinic in, you know, earthquake struck Haiti, but, you know, the principle's the same.
Yeah.
And so for whatever it's worth, when I struggle with that, number one, I look for ways to make that part of a compassionate practice with myself, with my clients. We're going to bring it into the room if that's appropriate. Hey, here's how I missed the boat. Let's talk about it. And then really honoring my needs as a person, not just for my clients, but also I'm a person too. So if I came to Earth to be of service to people, well, guess what? I also am, you know, I'm also a person. So I qualify as being one of the people I came here to take care of. That doesn't make all them feelings magically disappear, but those are touchstones for me that help me with that distress. So I don't know if any of that was relevant or resonated for you, Andrina, but that's how I kind of think about it. Okay, and we'll come back to some of that stuff for sure, but I'm going to get through the rest of this, so we'll move a little more quickly through this middle part, and then we'll get more to what we've been talking about so far. So the last one, I'm just going to put this in here that this is subtle, but I've noticed this for myself. One of the ways that I noticed myself insulating from the pain was by not listening as carefully. And I do that sometimes by like jumping ahead. I hope I don't say it out loud, but I can hear a client sometimes, and in my head, I'll go, oh, I know where this is going. And some of that is from being experienced. You've heard a lot of stories at this point, you know, but I've learned that when I'm falling into a habit of doing that, or I'm noticing myself doing that, or any form of distraction, I'm thinking about what I'm going to have for lunch. I'm thinking about a show I watched last night. It's a way that I am maybe subtly and hopefully not noticed by the other person, but it's a way that I am distancing myself. And that is a form of protecting. So to get back to your point, Andrea, I've learned to try to notice that without condemnation. It doesn't mean that I'm a bad helper. It doesn't mean that I suck. It doesn't mean that I have compassion fatigue, in the sense of, I'm no longer a compassionate person, but it does mean that I'm trying to protect myself from pain. And that is an elemental part of being a human being. That's very understandable. So I try not to condemn myself for that, but it does make me look more closely, just like I would with a client. If a client is avoiding pain, I'm not going to yell at them for that. I'm going to try to understand it and bring some awareness to that and find out what's going on. What is the pain? At what point did it become unbearable? What do we need to do with that? So it's just another little signal for myself that I've learned over the years to pay attention to. Okay, so this is all review. We don't need to go through it, but when I do this with audiences that are less trauma, where I try to bring this back up. So these are the reactions that we go to in fractions of a second, far faster than we're aware of it. So these are not choices, these are reflexes. When something starts to hit those buttons of, this is more stress than I feel like I can tolerate in the moment. And that's what it looks like. And when we're exposed to it a lot, it looks like that. Okay, so this is really important. This is sort of the hinge of the whole session. I mentioned earlier that most of us do what we do because we're highly empathetic. It gets us a lot of those secondary rewards, right? It's satisfying when we use our empathy to help someone with a problem. When someone goes, gosh, you're such a good listener, you're so empathetic, we're like, I know. Like, we just like it, right? It's a big part of who we are. It's what we value ourselves to be. But as the research has advanced in the past, I would say 7 or 8 years, we're learning that empathy is actually the engine of burnout. So we have to become more educated and more sophisticated about how we understand empathy, because empathy is not just one thing. If you asked me before what empathy is, I would say it's feeling the feelings of the other person. And now we understand that that's just one of 3 different kinds of empathy. And some of the research that's been done has been brain imaging. So they do like an fMRI or something, and they actually in real time look at the activation states of the brain. And what they see is that there are 3 different regions of the brain, or 3 different patterns that show up when people are in different empathetic states. Now there's overlap, but they are distinct, okay? And the first one is cognitive empathy. Medical people tend to be good at this. This is where I can identify your feeling, but I don't feel it. So I can look at Michael and I can say, Michael looks mad, sad, glad, whatever. And I'm correct, right? I'm pretty accurate in the label, but I don't feel it. I don't share that. Medical people kind of have to develop this because, if I'm an ER nurse and I'm recommending pain medicine, if I feel the pain of everyone who walks in, I'm immediately overwhelmed. I can't do that. So being able to accurately assess pain without sharing it is a really critical skill for me to have. So I always, tell my audiences this: if you work in medicine or someone who does, I know that Nicole couldn't be with us today, so make sure to tell her. Medical people are good at this, and the other group of people who are really good at this are sociopaths. So that's a fun fact, right? Sociopath is very good at knowing how you feel. They can pretend that they share it. They don't at all. They feel great, right? And sociopaths tend to feel either very, very angry or fine all the time. But they can pretend that they can feel your pain. So doctors, sociopaths, there you go. Yeah, again, I like to tell that to every medical person I know. Emotional empathy, we've already talked about. This is where a lot of people in the healing professions tend to come in, is we tend to be highly empathic. But as we talked about, emotional empathy may make us really good at helping the other person feel very seen and understood. And it's an important tool, but it can open us up to risk, because if I'm highly resonant with Patricia and she's dysregulated, well, guess who's reflecting that dysregulation, and to some extent feeling it myself, right? So that's why when I'm around people who are in pain over and over and over and over, and I'm emotionally connecting to that, even if it's not as severe, I am over time getting the same wear and tear that all my clients are experiencing. And that is what drives what used to be called compassion fatigue. The newer terminology that I prefer is empathetic distress. And over time, that distress can become an injury. So I prefer to talk about empathetic injury rather than compassion fatigue. I think it's more accurate and it's less insulting. Now, the last one, and this is where we're going to spend the rest of our time, is compassionate empathy. So compassionate empathy sort of is, it kind of bookends the cognitive empathy. You've got the 2 C's there, which I kind of like. Compassionate empathy, we could say that compassionate empathy is like a dual awareness, okay? So with emotional empathy, we can feel so connected to where Candace is with her emotions that we can almost sort of start blending and merging with that and lose a sense of ourselves. Where I learned that I had to do this is when my practice was almost exclusively families dealing with pediatric cancer. I see much less of that now, but for like 15 years, that was almost all I did. And I had 2 sons who were young at the time. And what I learned was that if I over-identified with my client as they were talking about their sick child or losing their child, I could easily become overwhelmed with terror and pain. I was just too swamped by what they were going, because I had that you know, just that shared awareness as a parent. So I realized that what I had to do sometimes, and again, hopefully not, this is a very deep internal process. I don't think my clients are aware of it, but sometimes I would notice getting flooded like that. And I would have to sit and remind myself, my kids are okay. Maybe they won't be tomorrow, but today they are okay. Neither of my kids have leukemia today. And that helped me. At first, I felt some guilt about that. I felt like I was distancing from my client's pain, but really I realized later, and as I learned about this, what I recognized I was doing was I was grounding myself in my own okayness. Okay. It's not, wow, sucks to be you, right? It's not cold, but it's a sense of you are in the water and I am in the boat, and I'm trying to pull you in the boat, but I'm in the boat. I am not in the water. I am basically okay. And we can relate to that in a trauma sensibility with that sense of groundedness in terms of presence, right? Like someone asked Vander Kolk, what does it mean to be grounded? Because we use that word a lot. And he said, for me, being grounded is I know, I can feel, and I know that my feet are on the floor and my butt is in the chair, right? That sort of body deep, that deep gut awareness of I am here, I am me, I am not you. And in this moment, I am basically okay. So I think of it as that sense of okayness with a profound sense of the pain of the other person, right? So I'm very attuned to you. I'm very clear about where you are, and I'm maintaining that balance with my own awareness of myself. Now, so far, I've really described cognitive empathy. What makes it compassionate empathy is that it's accompanied by a warmth, right? So it kind of ruins my joke. Actually, I think a lot of medical professionals are actually practicing compassionate empathy or can practice compassionate empathy. Compassionate empathy is you are in pain. I'm aware of your pain. I can accurately identify your pain. I am not in pain. I can stay grounded in that awareness at the same time. And it's accompanied by a warm heart. I have a sense of warmth and caring for you. I have a wish for your well-being. If there's a way that I can contribute to that, I will do it. And if I can't, then I'm going to hold that faith, that possibility that someday you can feel better. I may be able to see a path towards that. I may not. So again, I relate this to my work with bereaved parents. I don't know if any of you have ever done any kind of that work, but it is, I will tell you, there is not a psychotherapeutic skill in the world that takes away a spoonful of that pain. There just isn't. I think it's among the worst pain a human being can endure. So and how long does it take to heal from that? I don't know, your whole life, right? So I don't have a little worksheet. I don't have a reframe. I don't have anything. What I can offer in that moment is my presence, right? I can tolerate their their pain, and that's hard to find, right? So sometimes simply letting someone cry for an hour is a big deal. And I usually don't say this to clients because it's so far away from where they are that it sounds insincere, or it can even be me trying to comfort myself. But what I tend to meditate on when I'm in the room with that kind of pain is I carry faith that someday they can experience some kind of peace and healing. I don't know when that will be. If there's ever something I can do to advance that happening, I will absolutely do it. Sometimes there's nothing anyone can do. But we use the term kind of holding the space, and that's what I think of. So that, talk about spirituality. For me, that is a deep practice of faith, not connected to any particular religion. If a client is reaching that on their own and they want to talk about their experiences of that, then I can join with that. But maybe it's something I just hold for myself, the belief that someday they can experience something other than pain. You get me? So that compassion sometimes translates immediately into action. And interestingly, they did a small study of doctors where they taught them, and we're going to do an exercise, to move from emotional empathy, where they maybe felt overwhelmed by a client's pain, into a state of compassionate empathy. What they found was that the doctors then chose their medical interventions more effectively than when they were emotionally joined and overwhelmed, which makes sense, right? If you're flooded, if you're panicky, if you're shut down, you don't practice as well. So when there's something to be done, when we are in a stance of compassionate empathy, we are more effective at what it is we're going to do. But I also think compassionate empathy is a way to have that resilience, to be able to be in the space when all we're doing is holding space and offering our presence. And sometimes that's all we're doing. Right. And I don't want to say all in a minimal way. Sometimes that is a profound practice and a profound gift, but it's not the same as being able to fix it, Okay, so very briefly, here's what this looks like. If we talk about empathetic attunement, generally speaking, if you're with someone who's relatively regulated and you're emotionally attuned to them, or you're kind of emotionally connecting, that's fine. It's when they go into a state of dysregulation, or we're triggered into our own dysregulation, that we move into that empathetic distress. And a compassionate sense is when we move back into that sense of okayness, right? I am okay. I am not you. I can offer my awareness. I can offer my caring. I can offer my skill if it's applicable. I can offer my presence to you and my compassion to you. But I am not you, and I am not getting flooded with your pain. And the truth is that if we're very self-aware during let's say a session, we might move in and out of these states, right? So it's not about being a good, and supervisors, by the way, same thing, because you're talking to your staff, they're relating their experiences or what they're doing with their clients, what have you. This is not about staying in some perfect Buddha-like pose for all the time. It is about self-awareness and self-regulation, noticing where you are on this pyramid and being able to shift where you are. And that was what was also really interesting about the research. Is I'm going to teach you guys a technique that actually changed the brain pattern, that moved people out of emotional empathy and the potential for joining or flooding into a compassionate stance. So that's pretty cool. Just, this is self-evident, I think, but in order to move where you are, first, you've got to be aware of where you are. So we are constantly cultivating self-awareness. And Andrea, for what it's worth, I think while you sometimes have some painful thoughts, your practice of looking at each session and paying attention to how you feel is a way that you cultivate that self-awareness. I would bring a little more compassion into the conversation, maybe. But that's a really important skill. And when I taught grad school, the students were constantly focused on learning about other people. So they had their DSM class, and they had their mental health class, and their counseling class, and they were learning about their clients. I would always try to bring into my lectures with them that that's only 50% of the work. That if you're doing a traditional, one-on-one session with someone, they're only 50% of what's happening in the room. The other 50% is you. And so I think, right? So what I think we don't, it's hard to teach this, but I don't think students get enough exposure to it. we as clinicians know that as you are going throughout your career, it is a lifelong learning. Some of it you are learning about human beings, but you are, I think, equally engaged in learning yourself. And so the more we are attuned to how am I feeling? How am I reacting? What's going on? Am I checking out? Am I freaking out? What's happening? What's that self-talk? It's like this, it's like having two radio stations that you're tuned to at once. And one of them is a constant flow of information about yourself. So I think that's a deeply skilled practice that we develop over a lifetime. Then the second part is regulation, right? If you know where you are, now you need to have a way to get out of it, right? You've got to be able to move yourself. So I think we all have different ways of doing that. For me, I always have a beverage, like I always have something to drink. It's a way to cover up if I don't know what I'm going to say. It gives me a second. It's also regulating. Swallowing is regulating. Having a warm cup of tea in my hands gives me a sensation to kind of orient to. So I think a lot of us develop our own little tricks and things that we do. But as I said, we're going to do an exercise that has been demonstrated to actually shift people. So yeah, this is just another way of mapping it. This is adapted from Deb Dana, who does great work with polyvagal theory. We've not done any polyvagal work in our trainings together. That might be for another day. But this is how she helps clients map out that body awareness, emotional awareness, and thinking awareness. So you might want to adapt this for yourself in terms of what does it feel like when I'm comfy and grounded and I'm in my own okayness, versus what does it feel like in my body when I start freaking out? What does it feel like if I start shutting down? So quickly, these are examples of what compassion can feel like when we're experiencing it. Again, I'd spend more time on that, but there are lots of strategies for regulating in the moment, and we tend to teach these for clients, right? So breath strategies. One, I'll do a quick one with you guys that a student of mine just taught me, actually, that I really like. It might be the simplest breath strategy I've ever learned. So everybody just kind of sit in your chair if you choose to. Let yourself, ground through your hips into your chair. Let your feet be on the floor. If you're comfortable, you can have your feet flat on the floor. And then take a breath and breathe down into your right foot. And maybe even like wiggle your right toes, maybe scrunch up your right foot. Let yourself feel your right foot. And then release the breath. Now take another breath in and breathe down into your left foot and feel your left foot. So maybe you wiggle your toes, maybe you kind of scrunch up your foot, whatever's comfortable. Obviously, don't do anything that strains. I think I forgot to tell you to breathe out. You should breathe out. And now you're going to breathe down into your belly button. So breathe down, all the way down. Breathe it out. Now we're going to do one more. You're going to breathe down into both feet. So breathe in. Down into both your feet. Feel both your feet on the floor. You can even tap your feet. Breathe out. And notice how you feel. You might feel a little more in your body, a little more aware of your body. So those are some things that I might do in my session. And again, you can do that really unobtrusively. And 4 or 5 or square breathing, where you breathe into a count of 4, breathe out to a count of 4. There are a lot of different breath strategies that we use with clients. I will often try to make sure that I move around between sessions. That helps me. I noticed that I put on some weight during the pandemic because I was at home where all the snacks are. And I think eating is regulating for me. So I noticed that I got into a habit of eating a little snack between sessions, which maybe was not so great. And I'm kind of working on right now. But be aware that eating and chewing and swallowing is very regulating for us. So there are things we can do that are regulating. But there's a larger practice that I'm going to do with you guys that was actually studied with that brain imaging to move people into a compassionate state. It was a small study, right? So we'll have to see if it's replicated. I suspect that there are similar things. We're going to find that there's a much wider range of things that move people in and out of that state. But I'm going to teach this to you guys right now. Do we have an even number of people in the room or an odd number? We have 5. Okay. So I'm going to have you guys do this on your own. Normally with an even number, I would partner you up. So you can do this live with someone, or you can do this sort of imagining. And again, this is voluntary, so participate in if it feels okay. If it doesn't, it's totally okay. To do this, we're just going to sit in our chairs just like we were. Again, maybe kind of like wiggle in your seat, maybe let yourself sit up. You want your core to be awake, your feet flat on the floor if that's comfortable. You can close your eyes if that's comfortable for you, or you can just have a soft gaze looking down at the table. Both are fine. And here's all we're going to do. This is very, very simple. So I'm going to take you through a series of intentions that you will silently set for yourself in your head. Okay, so I'll say it and you'll kind of set that intention for yourself in your head. And then when we're done with those, I'm going to ask you to imagine switching your focus. And I want you to imagine someone that you really love sitting across from you, right? So not a client, not an employee, but someone that you really, really love in your life sitting across from you. Sometimes I'll pick one of my kids, and then when I do it the next time, I'll pick the other kid. So you don't have to feel like you're playing favorites, but whatever works for you is fine. But it should be somebody that you really, really love and care about. And some people, if you have a religious tradition and you want to picture their guardian angel or, whatever, or a circle of healing light, you can do that. But you don't have to visualize anything else. You just need to be able to see that person sitting across from you. And we'll go through the same set of intentions, but this time you're setting it for them. Okay. So if everybody's down with that, let yourself just settle into your body a little bit. I drink a little water for my voice. Okay. May I have happiness and the causes of happiness. May I be free from fear. May I be free from danger. If I do experience danger, may I be free from physical harm. If I do experience physical harm, may I be free from physical suffering. If I do experience physical suffering, may I be free from emotional suffering. May I be free from harm and free from fear. May I have happiness and the causes of happiness. So now go ahead and in your mind's eye, switch your focus, turn it outwards so you can now see this person that you really, really love sitting across from you. May you have happiness and the causes of happiness. May you be free from fear. May you be free from danger. If you do experience danger, may you be free from physical harm. If you do experience physical harm, may you be free from physical suffering. If you do experience physical suffering, may you be free from emotional suffering. May you be free from harm and free from fear. May you have happiness and the causes of happiness. And now just rest for a moment where you are. Just take a second. Nothing to write down, nothing to accomplish, nothing to fix, nothing to buy. Just being. We don't often just let ourselves rest in our being. And sometimes it's nice to connect to the knowledge that in this moment we are complete. There's nothing to check off, nothing missing. Right now, in this moment, we're not lacking for anything. Go ahead and release that completely. And in our last minutes together, let's just check in briefly. What do you guys notice as you check in with yourself after doing that, or things that caught your attention as we were going through that? What did you notice about your experience?
I pay more attention to just my breathing pattern, even just even me coughing and, you know, my eyes fluttering. I was just more conscious with the actions of my body internally
Mm-hmm.
and me swallowing.
I love that. And one of the things I think that specifically can help insulate us is that we carry a lot of responsibility as helpers. And, you know, for myself, I catch myself, especially if I'm starting to freak out a little bit. Oh my gosh, what am I going to do? Where's this going? How am I going to help this person? Blah, 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 blah. And that's all fine, right? Like there's nothing good or bad necessarily about thinking about that stuff, but it takes us out of the present, right? And that's where all our stress is in the future. So taking a second to just drop into your body awareness, I think is really powerful in being able to say, I don't need to know all the answers to that right now. I just need to be in this room. Whether we're offering a client our presence or we're just trying to manage our own worries, being able to go, I'm just right here, which I think is why all over the world, a lot of meditation or contemplative prayer starts with the breath, because you can only breathe in the present. You can't store up breath for the future. You can't rebreathe some breath that you didn't do a good job on last week. You can only breathe now. So I think that's really significant that's kind of where your focus went. Any other observations? Gosh, I wish I had longer to talk to you guys about this, but anything else that jumped up?
Well, I was kind of laughing when you said there's nothing to check off, there's nothing missing, because that's my life. What's
Yes.
missing? What has to be done? What has to be checked off?
Yep. For
Right.
sure. And I do a longer presentation of this with a more of a, I have some material from Taoism and Buddhism that I think are helpful. But to your point, Patricia, one of the things I really like is from a Taoist perspective, we look at every event or experience as neither good nor bad, but we do look at the balance. So your ability to forecast what's needed next, what's needed next is super important for what you do, right? It is a great strength that you have. But when it's out of balance, it's exhausting, right? There's the other side of it. So that moment that we take to go, oh, I'm just for this moment, I'm right here. And I can pick up the list in the next moment, and the list has a purpose, and that's great. But for this moment, this is what I'm doing. I think when we talk about relieving our stress or carrying our cases in our head, this is where I want to wrap up with you guys super fast. Well, I have to say this, the meditation that we just did is a small version of a loving kindness meditation. I believe that this exists in every major religion in the world. It doesn't have to be linked to any particular tradition. If you liked this practice, the full practice of it goes from, you always have to start with yourself, which as helpers is good practice for us. Then you see the face of someone you really love. Then you see someone you like. Then you see someone that you're kind of neutral about, and then you maybe see someone you're more challenging, and then you picture, I don't know, Hitler, and then you expand it to all beings in the universe. So this is an ancient practice. If this resonated for you, you can build this into whatever mindfulness practice or prayer practice that you have. But that little snip that I did of like setting the positive intention for the self and then setting the compassionate intention for the other is what shifted the brain state in the imaging. They watched it in real time, shifted it from emotional empathy to compassionate empathy. So that's what that was. But if this spoke to you, if this resonates for you, you can build this into, and you can expand it if you want, into a regular practice. The last thing I want to talk about is going back to what you were talking about, Patricia, and that is ritual. And again, this is ritual with a small r. This is not religious ritual, although religion can be a powerful source of ritual for many of us. This is more about those little routines that signal to us that we can be in the present moment. So for Patricia, for you, it could be, I am putting my list away. And when I work at home, that stays on my work table and I don't bring it to bed with, whatever. There are ways that we can signal. Liminal just means doorway. We're moving out of the doorway from work to home or whatever. When we work from home or during the pandemic, these became super important. Cleansing rituals were sort of washing off the day. I worked once with a police officer, and she said that when she could, her practice was she would come home, she would change out of her work clothes, if she was in uniform that day or whatever, before talking to anybody, she would change out of her uniform, she would shower and change into her like comfy clothes, whatever, and then she would engage with her kids and her family as a way of washing away or leaving behind whatever ugliness or pain she'd had to deal with during the day. Now, this water is deeply symbolic to humans. That's why it's a part of so many religious traditions. It can be washing your hands. It can be whatever. When I first started doing psychotherapy, my clients weighed on me. I struggled with not thinking about them constantly. And at the end of the week, I would go swimming and I would specifically think about washing them off in the water, washing off the stories. I can't say that it's like, a perfect light switch, but it did help signal me in a deep, deep way. Humans experience ritual and story very, very deeply. So in my head, going back to some of your comments, Andrina, that kind of relentless self-talk. Mm-hmm. Sometimes I think when we try to intervene with more thoughts, it's just thoughts, right? Just kind of chasing each other around. Ritual, story, symbol speak to us in a deeper way. And sometimes that might be a way to get into that place of like, I am releasing this. And this, to wrap this up, I know we're going a minute over, and I wish I had more time with you guys, but I will say this, to go all the way back to that quote from Pema Chodron, when we are able to bring more skill and awareness to that self-awareness, right, in the moment, when we are doing what we need to do to take care of ourselves, if any of those things on that list jumped out at you about, oh, I might want to address this area of my life or that area of my life, that's really important self-care. But also that cultivating that awareness of where am I in myself? Where's my level of activation? Where is my compassion? Where is my empathy? If I'm getting flooded or joined or I'm distancing, how do I step into that compassionate, empathetic stance and stand there in a place that is open but protected, that is reaching out for the other person but grounded in myself? And what are the practices or rituals or symbols that I can use to release that when it's time to release it? That's how I think we can come back to what Chodron was talking about that open heart, but not in the sense of, go ahead, world, go ahead and just, suck it all out of me. But that place of, I can do this from a place of wellness and health and compassion for myself, as well as for the people that I serve. That's how I think we can embody what Pema Chodron was talking about. And I'll wrap this up with this. This is from a friend of mine who's a local meditation instructor here in Columbus. And she likes to say, every moment contains within it the potential for everything it needs. And that has many, many, many different applications. But as a practitioner, what that means for me is that even when I'm flooded, even when I'm despairing, there is a place that I can step into where I can be in a place of wholeness and not pouring out of that empty cup. And that's helpful for me and my practice. I hope some of this resonates for you. I hope some of this is helpful for you. And once again, we are so grateful that we got to spend this time with you guys. So thank you guys so much for inviting us in for this little bit of time.
Thank you.
Laura, can you tell me quickly those intentions again? You said the first one was happy.
Yes, I will actually, what I can do is I'll just email it to you. I print this out for clients, so I'll just email it. And if you're looking at the practice in a larger perspective, there are different names for it. Again, I think human beings have been doing it forever in different ways, but from a Buddhist perspective, it's sometimes called in Tibetan, it's translated as, or the name is Tonglen, Tong, second word Len. Or you can also find it in English under loving kindness practice. So you can find it lots of places, but I'll take you through the particular shortened version. I'll just email Patricia and send it to you guys.
Okay, thank you.
Of course. All right. Thank you guys so much. It's always so fun to talk to my Cleveland folks, and hopefully we'll be in touch and talking to you guys again.
Thank
Okay.
you.
All right, thanks,
Okay.
Laura.
Bye, everybody.